This is our curriculum, and this is how we are going to cover the CNS. Today we are just going to cover MR basics and phacomatoses. Next time will be tumors. It is a long one, this tumor, and I will spend some time on this. And I also, this will also help develop your anatomy and things like that. Anatomy I'm going to cover today also in quite a bit of detail. And today's session, I'm going to go especially slow, particularly because the ST1s and 2s, I just want them to get a feel of MR and things like that. Now, these modules, which are vascular, white matter, infection, congenital trauma, these are going to be much easier. So these three are the heavyweight ones. And in the last session, of course, will be spine, mostly the cord. I will refer to anatomy in each and every, but today in greater detail, and in tumors also in greater detail. The point is that in examination, many a times, the viva ultimately heads up into anatomy. And for example, you get a paracellular meningioma, which goes into the cavernous sinus, into the Meckel's cave, and encasing, let's say, the basilar artery, etc. So all of these things will be asked in anatomy. So the examiners at times, they just point out that, what is this, what is this, what is this? And if your anatomy is good, only then you can answer those questions. Right, so candidate 1, can you please raise your hand? Candidate 1. Just bear with me.
Hi.
So you are with us, candidate 1?
Yeah.
Okay, so on this film, I've put in about 12 images. I'm going to point out on the sequence, on an image, and you are going to just tell me what sequence it is. Okay, can you please name the sequence here?
So the fluid is attenuated and the white matter is dark, therefore it's a flare sequence.
It's a flare sequence. This one?
I think this is T2.
This one?
This is also T2, I believe.
Okay, this one?
This is T2 as well. Yeah, T2.
This?
I think the white matter is still fairly dark, so I think there's a T2 weighted sequence. Yeah, it might be additional data on it. I'm not sure.
Okay, this one?
Fluid suppress, and it's white matter white, which is T1.
This one?
This is T1 as well.
This?
T1.
This?
T1.
This?
T1 as well, I think.
Hint, what is this? Where I am?
Is that with contrast?
Okay.
T1 with contrast.
This one?
So the dual sinuses appear hyper intense. So I think this is a T1 with contrast as well.
And this one?
Likewise, T1 with contrast.
Okay. Okay, well done. So you got this one.
Sorry?
What I put in. In old days, before the electronic exam, this is what used to happen. The examiner used to have multiple films, and they had they were pointing out, what is this, what is this, what is this. By the way, one or two examiners, they still have got some scan films on Cyrex, though, so somebody can show you like this. Having said that, usually they will open a sequence for you, and your eyes have to be developed that what is this sequence. And so in brain, it is very important. Similarly, post-contrast sequences, you have to understand that this is post-contrast. In other parts of body, at times it's a bit harsh to for the candidate or for the expectation of a candidate to pick up that this is a post-contrast, for example, in spine, etc. But in brain, you have to pick it up that this is post-contrast, and there is going to be evidence. So let's see a few points to remember. But having said that, first of all, this sequence, everything else was fine. This one is a flare sequence. And the key here is, just like this one, the key is that CSF is black and the white matter is also black, dark, and you can see the fourth ventricle here. So my experience is that usually people do confuse flare with T1. And why? Because in both of them, the CSF is dark. So these are the basic sequence is easy because now T1 and flare, first thing, what is common? The common thing is that on both of them, the CSF is dark, and that is why they are confused. So the rule is, once you see the CSF dark, which is like water, like CT scan, look at the white matter, and you will see that on a T1 weighted sequence, the white matter is white, but on a flare, it is dark. So white matter is white on a T1, that's the take-home point. This is a PD weighted sequence, proton density weighted sequence. Please remember that many people don't use it. It is considered a sort of obsolete sequence in many departments. And
get right.
People don't do it. But having said that, the counter argument is that it's a free sequence. You don't spend any time doing a PD. It comes with the T2. And you just have to calibrate your machine so that it sends it onto the packs. People do use PD still to pick up some vascular abnormalities. I call it a poor man's angiogram. What happens is that on the PD weighted sequence, CSF is equal in signal intensity to the gray matter. So remember this rule. CSF is equal in signal intensity to the gray matter. So the vessels, for example, these filling defects here, they are black, they are dark. So that is why you cannot differentiate between the CSF here in the frontal horn as well as the head of caudate nucleus here. So this is one of the uses of PD weighted sequence. Now, this is pre-contrast, this is post-contrast. So, candidate 1, can you tell us what normally enhances on post-contrast sequence? When I say normal means it's not pathological. Over to you.
So the nasal mucosa and the vessels as well, of course, including the dural sinuses and the arterial vasculature.
Excellent. Anything else?
I think the fat may enhance slightly as well because there's some blood vessels within them. I don't think so you have the posterior pituitary bright spot, which is there normally anyway.
So what happens to the anterior pituitary then?
Sorry, that should enhance as well, I think.
Yeah, very good. Okay. So there are many things which do enhance on post-contrast sequence, and you have to understand that. Nasal mucosa, as was correctly pointed out, if you see this nasal mucosa pre and this is post, it is enhancing. Then all blood vessels, may it be arteries or the venous sinuses or cortical veins, they can enhance. Now, the fine touch is that the meninges, the dura and leptomeninges, they can enhance, but you have to be sure that they are not abnormally enhancing. On a coronal sequence, for example, this is a coronal sequence. If you see here, look at the dura. Let me change. So if you see this dura here, it does enhance. So this is still normal, but it should not be too much. So for example, it should not go around the corners like this. Similarly, you have to look at continuous slices, and it should not continue anteriorly and posteriorly, particularly on a coronal view. Then other than this, wherever, other than dura, wherever there is no blood-brain barrier, there will be enhancement. For example, pituitary, there is no blood-brain barrier there, it will enhance. This is the anterior pituitary, this is the infundibulum, it will enhance. Pineal will enhance. At times, pineal enhancement is slightly delayed, but it can normally enhance. So this is the pineal which is not enhancing in this particular case, but you can include it in the list. So these are the things which will enhance. Key thing is the meninges, and I will show you cases where there will be abnormal enhancement, which will be contiguous in serial slices. Now, this is the use of PD weighted sequence, and you can see this axial and candidate 1. What is the finding? So just look at the vessels, please.
Sorry?
Just look at the vessels and any finding you pick up.
Yeah, just looking at them now. So these are axial slices, PD weighted images of the brain. I think in the third column, second row image, the vessel appears quite ectatic. I wonder if there's a ACOM aneurysm.
Okay, very good. So if you see here, there is an aneurysm of the anterior communicating artery, and you can understand that because it appears as a filling defect, and the CSF is equal to the gray matter, how beautifully you can see it. Similarly, if you see this thing carefully, this is the cavernous portion of the internal carotid artery, and you can see a bit of thickening. Nothing more than that. A complete occlusion of the cavernous portion is an exam case. It can be seen in other sequences also, but PD is the best. Having said that, many departments now do not do PD, as I pointed out. So this was an MRA of the same case with the same finding. So from here, we come to the diffusion weighted sequence. So we are going through the sequences and what is their use and what is their use for the exam, etc. And how are you going to pick it up. Diffusion weighted sequence, of course, is the king sequence as far as acute infarction is concerned. In mouse models, it has been documented to pick up acute infarctions within 10 minutes, and in human beings maybe 25 to 30 minutes. Diffusion, I am not going to go into physics, but the point is that whenever you see a diffusion weighted sequence, there will be a DWI sequence and there will be an ADC map. So see here, how does it look like? It looks like a dirty looking flare, but the resolution is not very good. And it is a sort of fat saturated. The ADC map, on the other hand, appears like a dirty looking T2 weighted sequence. So this is how diffusion and ADC, they look like. Now candidate 2, what is your finding on this one? Sorry, candidate 1.
Yeah. I've been presented with three Excel images, three different sequences. The one on the left is a T2 weighted sequence, and there's a DWI and an ADC map.
What is,
Sorry?
which is, where I'm pointing out? What sequence is this?
Flare, sorry.
Flare. So this is a flare sequence.
Apologies, yeah.
Yeah,
So,
this is flare, this is diffusion, this is ADC. Over to you.
yeah, so there is a high signal lesion in the lentiform nucleus on the left side, which has got high signal on DWI and low signal on the attendant ADC map. Appearances are suggestive of possibly an infarct or possibly an abscess as well. Yep.
Abscess versus infarct. So why have you said abscess?
Because there will be restriction. Sorry, there isn't any rim around it actually. So I think it's more likely an infarct. I apologize. Yeah.
Okay. Anatomy-wise, what is lentiform nucleus made up of? Anatomy question.
So the putamen and the globus pallidus.
So medially, name the nucleus medially.
So that would be the globus pallidus.
Okay, fine. So a bit of recap of anatomy, and these questions which I am asking about anatomy have been asked in the exam. They are very simple questions, but if you know it, it becomes very simple. If you don't know it, it becomes difficult. So just a recap. So this is, the basal ganglia level, which is a very important level in stroke imaging, where this is what we call the deep gray matter. There is a concept of cortical gray matter and the deep gray matter. Deep gray matter includes head of caudate nucleus here, the putamen here, and this is the putamen, this is the globus pallidus. Overall, this is the lentiform nucleus. This is the thalamus. Now, lateral to this is the insular cortex, which is a very important part of cortex for the exam because acute infarctions will come in the exam, insular ribbon sign and things like that. So from here to here, usually on imaging, here is what we call external capsule, but anatomically speaking, it is divided into three structures. This is known as external capsule. Then comes another gray matter, which is known as claustrum, and then is the extreme capsule, and then is the insula. Having said that, you don't have to go into these details because, on a usual 1.5 Tesla or a CT, you don't see all of these. And usually we just use the word external capsule. So this is the lentiform nucleus, external capsule, and then the insula. Now, diffusion weighted sequence is, as we have pointed out, King sequence vis-a-vis acute ischemia. And acute infarctions or strokes can be divided into these words as far as MR is concerned. And hyperacute, which is 0 to 6 hours, then is acute 6 hours to 4 days, then subacute 4 to 14 days, and then is chronic. Please remember that these days are not etched in stone, and don't think that a new day will, the changes will be absolutely black and white. There is a bit of overlap. Having said that, if you see the signal on DWI and ADC map, till the first 4 days, the signal does not change. So this is the take-home point for you to remember. Till 4 days, there is no change. And what is this word? This is, I've taken from requisite series. I like this word. This is bright on DWI and low on ADC map. Instead of high, the word which is used is bright. So I want you to remember this. Bright on DWI, low on ADC map. Because then what happens between 4 and 14 days, this brightness decreases and it it becomes high in signal intensity. And ADC map becomes what we call pseudo-normalized. And in chronic infarct, this will be high as in T2 because of T2 shine through, and the ADC will also be high. So this concept is important for you to remember. Now, if you see, this is from literature, a case where this is 4 hours, 8 hours hours, 10 days, and 17. So if you see this area here at 8 hour, this is bright on DWI and low on ADC map. And on 10 days, a bit of change is there. You can see this ADC, it is not as black. And on 17 days, it is not all that bright. It is high in signal, and this is also high in signal ADC because of T2 shine through. So, okay, candidate 1, this is your last case. This case had a stroke and then was discharged and then came back again with acute type of symptoms. And to help you, the symptoms are on the right side. So on the left side, can you see an acute stroke on the left side?
So in the patient anatomical left side, there is restricted diffusion in the left frontal lobe, and possibly in the posterior aspect of the lentiform nucleus as well.
Right.
Will be keeping with a stroke with right-sided weakness and dysphagia.
Right. So do you think that we can see some evidence of the previous stroke? So, compare, let's say, this area with this.
So there is slightly high, well, I would say slightly reduced DWI signal in the right lentiform nucleus, and slightly high intensity there.
I want you to describe this area for me. Just this one, where I'm pointing out.
Okay, so there's a DWI brightness around the right lentiform nucleus.
Is it the lentiform nucleus? We are slightly superior to that level. If so you see, this is the body.
So it will be the corona radiator.
Right. So we were debating the word. You use the word bright here.
Yeah. So it will be high.
Right. Then what is this, or what is this?
So it is less bright than the.
So this is exactly why I told you that I like these words, right? On DWI, acute, hyperacute, bright, and then subacute, high. It's a subjective type of a thing, but these words are, have got a meaning. If you see here, this is bright, and this is bright, and this is high. And then you compare it, this high with the ADC. And what do you think is the ADC?
So there is shine through there. T2 shine through.
Shine through. So, and on the other hand, the acute infarction had low ADC. So this is that concept of subacute. So I go back, and subacute, high signal, T2 shine through, pseudo normalization or shine through. So this is going into the territory of subacute to chronic, and in chronic, this ADC, if you debate, part of this ADC is slightly high and slightly iso-intense. If you look at the parenchyma here, and you will agree that it is, so part of it has got a subacute type of component or chronic component. Okay, candidate 1, thank you very much. Well done. Well done. And candidate 2, are you with us?
Yes, sir.
Okay, now candidate 2, Okay, I'll still continue. Now, causes of restricted diffusion, this is from your new Chapman. There are many, everything which glitters is not gold. And similarly, everything which shows restricted diffusion is not an infarction. So, some of these things are important for you for your exam. And some of them are what I call beyond FRCR. I'm not expecting that they will show you in FRCR. The problem is that the bar is going up and up, and you never know. But having said that, I will just concentrate on cases which have come in the exam, and some of them are, I think, slightly beyond FRCR, so we will not concentrate on that. Now, if you see here, cortical, subcortical, focal. Cortical ischemia, hypoxic injury, these ones. Post-ictal change is post-epilepsy. Press, you have to know these two, but not. We'll cover them later on, but I don't consider them very, very important. Encephalitis, cerebritis, extremely important. Diffuse axonal injury is very important. Now, diffuse axonal injury has come in the exam many a times. I'll show you shortly, but not on a DWI. The problem is that, usually nobody will do a trauma scan with the, they will show you a diffuse axonal injury with micro hemorrhages or high signal on T2. So not for DWI. And CJD, etc., very important if you are in your clinical practice, but not for your exam. It's a bit too much for the exam. These ones are extremely important. Abscess, empyema. Please remember that many tumors can also show restricted diffusion, and some of the tumors which can show restricted diffusion are not even written here in your Chapman. For example, meningiomas. I've seen so many meningiomas which show restricted diffusion. So, classical question in the exam is about which part shows restriction. Please remember the take-home point, which is that in an abscess, the central part, which is the pus part, which is the liquefied part, that will show restricted diffusion. While in a tumor, the solid part will show restricted diffusion. And this question has been asked in the exam many, many times. Acute demyelination, as in acute cases of MS, can show restricted diffusion. And this is an important thing to remember, because otherwise I have seen this mistake being done both in clinical practice as well as in the exam, that people say that this is, when they say that some high, white matter abnormalities with that restricted diffusion, and they say that this is in keeping with lacunar infarctions. So please remember that acute MS plaques can also show restricted diffusion. Epidermoid is an exam case. Many a times it has come in the exam. Epidermoid is a cyst which is extra-axial. On a CT scan, it will appear just like CSF. You cannot differentiate it with, let's say, an arachnoid cyst. And this is how the case will come in the exam, particularly in, let's say, CP angle, as in cerebropontine angle, etc. And epidermoids show restricted diffusion. On the other hand, arachnoid cysts do not show restricted diffusion. This thing, osmotic myelinolysis, I will cover it, and it has come in the exam quite a few times now. As I say, bar is going up and up. Maybe 15 years ago, nobody used to think that osmotic myelinolysis will come in the exam. And the previous concept was, we used to call it central pontine myelinolysis. But now we have understood that it can happen without pons being involved. So we use the word osmotic myelinolysis. In any case, we'll cover it later during this module. So, candidate 2. This is a T2 weighted sequence. This is a T1. This is post-contrast. This is post-contrast. This is diffusion, as in DWI. This is ADC map. What is this lesion? How are you going to characterize this? Over to you.
Okay. So I'm provided multiple sequences of MRI T2 in which I can see there is a rounded lesion which is enhancing lesion on the contrast images with T1 hypo and T2 hyper with surrounding edema. On post-contrast, I can see there is a well-defined, it's encapsulated and enhancing. On diffusion weighted, with the ADC map, there is a restriction of diffusion involving the posterior cerebellar region on the left side. And this confirms that it could be abscess or it could be a metastatic lesion. So I will further correlate with the clinically and with the history.
Okay, so the patient has got a lot. You see, let me tell you, with your radiological features, you can make a diagnosis and you can discriminate between the two. So let me ask you that question as an examiner. Among these two, what is it? Give me one choice.
The abscess most probably because of enhancing ventral wall. And
okay. So what is this? What is this?
So it's the intraventricular extension of the and it's intraventricular extension or a debris.
Okay, fine. Okay, well done. If you see here, this is a very good case, and this is classical. So many times it has come in the exam. Classical scenario, tumor versus abscess. Now, if you see here, there is what is happening is that the central part, which is the liquefied part, has got restricted diffusion. This is the key. The liquefied part has got restricted diffusion means that this is abscess. Pus. In this particular case, what is happening that is also tracking into the ventricle, and actually within the ventricle there is abscess sitting here. If you look carefully on this post-contrast, you can see a bit of a level here, and actually this characterizes it that this is pus. And you have done well by picking up this enhancement, which is because of ventriculitis, and you can see a double rim also here on this T1 weighted sequence. So, so the point is that this is an abscess. Now, just to show you that plaques of acute plaques of MS, which we will cover in another session, so I'm not going to go in details. But having said that, I just wanted to show you this. This is a DWI which shows restricted diffusion. The plaques, active plaques of MS, do not behave like stroke. The ETC changes within 1 and 2 days. It changes very fast, but it will be slightly bright on DWI sequence. Some of the studies have proven that to pick up active plaques, DWI is a very sensitive sequence, and in literature, some people even suggested that it should be used as a criteria to say that the plaque is active or not. But having said that, in clinical practice, that has not been approved by any body till now, so or any consensus statement till now. So we still take enhancement as the sign of active plaque. Having said that, if something shows restricted diffusion, your index of suspicion should increase, and you might like to give contrast just to confirm it. Now, this is a case of herpes encephalitis, which shows restricted diffusion. This is, and you can see that this is bright on DWI and low on ADC, and this is not an acute infection. So herpes can also cause restricted diffusion. Okay, candidate 2, please describe this case.
Okay, that's this Excel slices multiple images of the CT brain, in which I can see there is a there is a rounded lesion or rounded hypodense lesion involving the left left parietal region. Yes. However, I can't see any intraparenchymal hemorrhage, or there is no involvement of the corpus callosum or no evidence of hydrocephalus.
Okay, I'll stop you here. Excuse me, I'll stop you here. My question is anatomy. Now, you said that there is no involvement of corpus callosum. Now, if you see here, this is an axial slice, ventricle and ventricle. This is the lesion, it is crossing the midline. And what structure will be where I am pointing out here, anatomically speaking?
So it is.
If I go to more
corpus callosum.
Yes. So the point is that corpus callosum anatomy on an axial slice of a CT, very difficult to see. You have to slightly stretch your imagination. Where is the corpus callosum? And this is the corpus callosum. Now, in this particular case, you can see that the lesion has got, heterogeneous density, slightly high and also low, which is sitting in the splenium of corpus callosum. Maybe, what would you like to do next?
I will do contrast enhancement.
Okay, so instead of contrast, we have got an MR, better for you. Yeah. So let me, because of time factor, I am going to point out the sequences for the audience. This is flare, this is flare, this is post-contrast T1, post-contrast T1, T2, T2, diffusion, ADC, diffusion, ADC, post-contrast sagittals. Over to you.
Okay, so there is a high intensity signal lesion involving which is crossing the midline and involving the splenium. Yes, so there is no evidence of any hydrocephalus or any intraparenchymal hemorrhage. So on the basis of these findings, which is showing the restricted diffusion on diffusion weighted with ADC mapping, I can my first differential is GBM, glioblastoma multiforme, or sorry, and second is lymphoma.
Very good.
If the
okay, that's fine. Anything else in the differential other than a tumor, as in a neoplasia?
Neoplasia, metastasis.
Oh. Right, I'll come back. Okay, I'll take over. Now, if you see, there are a few teaching points here in this case. First of all, corpus callosum anatomy is critical, and it will come again and again. I'll show you cases of, for example, diffuse axonal injury involving of corpus callosum. Now, this particular lesion is quite unique because it has got high density on the CT. If you Google it, high density CT lesions, it's slightly beyond 2B, should I say, what I'm telling you. It is documented that some of the tumors are high density. Lymphoma is up there because it has got high cellularity. On a CT, it can be high density. So here what happens is that there is a lesion which has got a bit of necrosis, which was that low signal on CT. It enhances. Portion of it shows restricted diffusion. For example, if you see this portion, it shows restricted. Your differential was absolutely fine. Now, one lesion, not in this particular case, but you can suggest it and then rule it out in the examination, is tumefactive MS. I'll show you cases. Tumefactive MS, as the name tells you, is MS, which appears a big lesion, which is like a mass, and it has come in the exam. In tumefactive MS, should not see this necrosis, etc. So that goes against that. So of course, on a CT, that will not be high density. So, but high density CT is, I think, slightly beyond 2B. Rest of the features which I'm telling you, you have to remember for your exam. Now, this is just to make a point. This is a meningioma, which shows beautiful restricted diffusion, and there are so many. Your book is silent on this, but I've seen many meningiomas which show restricted diffusion. Okay, candidate 2. This case presented with acute infarction, and the acute infarction is visible here in the insula, right? Now, anything around the brainstem, just concentrate on this sequence, this sequence, this sequence, this sequence, and this sequence. My question is, any extra axial lesion?
Yes, I can appreciate in the second last, no, the two segments, the third one image, in which I can see there is a hyperdensity in the left cerebropontine angle.
What is the differential diagnosis for this? What is the density?
Density is, it could be epidermoid, or it's low density, so it could be epidermoid, or it could be a infarct as well.
Extraaxial.
The meningioma.
Okay, so this is the DWI sequence. On DWI sequence, if you see there is restricted diffusion in that insula which goes superiorly also, there is ADC, low ADC. The lesion in this here, what you saw on CT, can you describe and give us the diagnosis?
Okay, so that's the multiple images of MRI axial slices in MRI sequences of the brain, in which I can see there is a high signal lesion involving the left cerebropontine angle, which is causing the restricted diffusion on the diffusion radial images with the ADC mapping. My first differential on this is, as it is doing the restriction, so it's epidermoid, or it could be arachnoid. As if there is a restriction, so first probability diagnosis is epidermoid.
Okay, so if you see here, the learning points here are that this is a T2 weighted sequence, this is a FLAIR sequence, this is of course DWI and ADC map. This lesion was low signal on CT scan. So on a CT scan, the differential can be arachnoid cyst versus epidermoid. On a T2 weighted sequence, you cannot discriminate between the two. Still, it is bright or white on T2 weighted sequence. But on FLAIR sequence, by the way, if you don't use DWI, FLAIR is a good sequence because you will see some signal inside where I am circling. But it's a black and white diagnosis on DWI where it shows restricted diffusion. Now, this patient had sinus surgery. Now, after sinus surgery, so the sinus surgery was frontal sinus surgery.
No. Hello.
The patient developed right about. Can you hear me? Candidate 2, can you hear me?
Yes, I can now.
So, is there an abscess on this scan or not?
As I can see, there is enhancing lean in the subdural area. So, and after post-sinus surgery in the frontal lobe, bilateral frontal lobe. So this shows that there is a post-surgical empyema, which is showing the restriction on the right side, right frontal lobe with the ADC mapping.
Okay. What's happening to the dura?
There is an enhancement of the dura as well.
How can you explain that?
So that shows there is some leptomeningeal enhancement due to infection.
So you're worried about infection and you use the word, is it leptomeningeal, Pecky?
Pachymeningeal, right, pachymeningeal.
Okay. Okay, candidate 2, thank you very much. And candidate 3, raise your hand.
Thank you.
Candidate 3, are you with us?
Yeah.
Okay, you please, I'm going into a teaching mode, so you just listen and then I'll show you another case. Now, in this case, the learning points are that, first of all, I've given you the history and you can see with that history, there is a fluid containing extraaxial collection here, collection here, and which shows restricted diffusion, bright on DWI, low on ADC map. So this is an epidural empyema. But another learning point here is that look at the adjacent dura. It shows enhancement. But if you look here, the enhancement goes bilaterally. So this is enhancement of the dura which goes bilaterally. So let's go back to anatomy, and this anatomy is critical. And this concept you will remember as far as enhancement is concerned, then pachymeningeal or leptomeningeal enhancement, as well as things like subdural hematoma, etc. So you have to know your anatomy of the meninges. So if you look carefully on this diagram, which is a coronal section through the upper portion of brain, this is the superior sagittal sinus. First of all, see that this is the bone, the scalp. Scalp has got an inner table and an outer table. And within that is the medullary cavity. Medullary cavity will have fat inside. So it will show high signal on many of the sequences of MR. Cortical bone here and cortical bone, the outer table, which will be black, just like cortical bone in, let's say, tibia or some other long bone. Now, superficially is what we call, scalp, and we are, as radiologists, we are less interested there. There is what we call Galea aponeurotica, which in radiology we never use this term, but surgeons, they use it because when there is a scalp hematoma, they say subgaleal hematoma. Having said that, this is not important for you. More important for you is what's inside. Now, deep to the inner table of the skull is the dura mater. Now, the dura mater has got two layers. The outer layer is adherent to the inner table. And this is the dural venous sinus. So what happens is, the superior right sagittal sinus, what happens is that this is adherent, and the second layer goes around it. So first layer is adherent to the inner table and the second layer goes around it. And it is in continuity with the other sided dura. So this becomes the fox. Now, if you see here, this red structure is the arachnoid. And the green one here is the pia mater, which is adherent to the brain, and actually it goes, dips into, around the perivascular spaces when the vessels, they are going into the brain. So with this concept, if this is arachnoid, this is subarachnoid space, and subarachnoid space has got vessels. On the other hand, the subdural space, which is shown in this white color, is just a potential space. Some vessels, etc., of course, they traverse through it, but there are no significant contents of it. Point to remember is that when there will be a subdural hematoma, it cannot cross the midline, because it will go along the falx and it will not cross the midline. And this is an important concept for you to remember. So pachymeninges, the term pachymeninges is used for dura mater and adjacent arachnoid. But when we use the word leptomeninges, it means arachnoid and pia mater. So in your book, there will be differential diagnosis of enhancement of dura mater or pachymeninges, and second will be enhancement of leptomeninges. So these two are very, very important for the exam. Now, with this overview of anatomy, okay, so this is from your Chapman, meningeal enhancement. Very, very, very important for the exam, this differential diagnosis. And pachymeningeal means dura arachnoid, and leptomeningeal means pia and arachnoid. Now, first of all, few things which are extremely important and which is overlap between the two. Let's get them out of the way. If you see here, neoplasia, metastasis. Metastasis is very important. So we call it leptomeningeal carcinomatosis. Sorry, yes, leptomeningeal carcinomatosis or pachymeningeal carcinomatosis, where it can occur with pachymeninges and it can occur with leptomeninges carcinomatosis. Granulomatous diseases are extremely important, and they have come in the exam more often than anything else. This include TB, fungal infections, but the biggest mimicker in neuroradiology, sarcoidosis. So remember sarcoidosis. And it has come in the exam so many times, and with at times also as a long case. If you don't know it, you will be confused what is happening. So we will cover sarcoidosis subsequently. So indirectly, metastasis will be in both differential, sarcoidosis, TB or fungal will be in both differential. Then we go into a few other things. Intracranial hypotension. This is extremely important. And till few years ago, nobody got this case, and now it is coming. So this is why I say the bar is going up and up. And many of the things which we used to consider that these are beyond 2B, they are now part, they are expected. You are expected to know that. Intracranial hypotension, I will come back to this. But look at this: lumbar puncture, shunting, CSF leak. All of this is the same structure. So I'll come back to this. And so with that, over to candidate 3. Because of time factor, I am going to tell the audience this is a flare, this is a PD, this is a T2, this is a T1, this is a T1. Over to candidate 3. Please, your description, please.
So looking at the different sequences in the MR, I don't see any focal lesions. There's no midline shift. There appears to be some thickening of the leptomeninges with some high signal in the T2 weighted images. But apart from that, I don't see anything. But it's very diffuse and it's leptomeningeal because it's in a gyriform pattern. But
which sequence are we talking about? This is the T2 weighted sequence. Are you talking about this sequence?
Yeah. This is, I think, probably it's normal, is it? I think it's...
On a T2 weighted sequence, you can never pick up leptomeningeal enhancement or things like that, because you are confused if it is the there is something abnormal or this is the CSF. Okay, hint. Something is abnormal on this sequence, which is flare. Your thinking is right. Think meninges, but something is abnormal on this flare. Let me give you a bigger image. Over to you.
Yeah, so the periventricular areas are likely probably just some white matter change, but again, the meningeal, I'm not sure, but the meninges do look slightly more hypertense than I would expect them to look in a flare sequence.
Which meninges are we talking about?
Just generalized, it's throughout.
So you see, I want to hear the words. Is it dura?
Oh, it's dura. So it's pachymeninge.
Right. Okay. So what do you think now? What will you do next? This is the exam question, by the way.
I would do a contrast enhanced MR.
So here is contrast.
Yeah, so I suspect on the flare sequence there is pachymeningeal enhancement of the brain. So yeah, so differentials of this would include intracranial hypertension. I don't see any other lesions, enhancing lesions. So yeah, diffuse pachymeningeal enhancement, and I would give a differential of intracranial hypertension.
Intracranial hyper or hypo?
Hypo.
Hypo. Very good. Well done. Okay. Now, if you see here, the learning points in this case is that look at this flare. And on this flare, this was the diploic space. This is the outer table. This is the inner table. And inner to the inner table is this dura. And it goes, this is of course the fox, and it is thickened. So take home point is that flare is a good sequence. On a T2, you will never pick it up, never. On a PD, if you see, it looks slightly bright, but even then because remember that the CSF is equal in signal intensity to the gray matter. So this is slightly higher and slightly brighter. But having said that, flare is the king sequence. Now, intracranial hypotension, we call it spontaneous intracranial hypotension, is an important case for the exam. So what happens there? What happens is that if you see this slide here, and you can take a picture of this, the Monro-Kelly hypothesis. This hypothesis in the Viva has been asked quite a few times. Indirect questions are, if you know this concept, what is the concept? The concept is that intracranial cavity is a closed space. There is skull. Within that skull are three things. First is brain tissue, which is basically made up of water. And then there is CSF. And then there is blood. Where is the blood? This blood is within intracranial vessels, may it be arteries or veins. But all of these things have to be in equilibrium. Basically, if something increases, another thing has to decrease. That is what it is, because it's a closed space. So what is the application? For example, a patient has got cerebral edema, and this is what they have asked in the exam, because of trauma or any other cause. Then what will happen? The brain tissue is increasing. CSF cannot decrease. CSF cannot decrease because it is a liquid. You cannot compress a liquid. We know that from physics. So what will happen? The vessels are going to be compressed. Initially the veins, because they are less compliance, or they've got more compliance, and then the arteries. So the patient will then get ischemia. So similarly, in spontaneous intracranial hypotension, what happens? There is CSF leak. The word spontaneous tells you at times we don't even know the cause. and at times we end up doing more spinal imaging, etc. One of the causes might be osteophyte, particularly in the thoracic spine, which has caused a tear of the dura. But many a times we do not pick up these findings on spinal imaging. But the CSF has reduced. Now, because the CSF has reduced, then according to this hypothesis, something has to take up its space. So what happens is that there is venous congestion. The veins, they get dilated. And within the dura, what happens that actually these are veins within the dura which are dilated, which are congested. And that is why you see this dural thickening. And when you give contrast, you will see enhancement. So I've seen over the years many cases in which we just pick it up, as an incidental finding and usually on flare. If the clinicians are worried about it, please remember the protocol. If they are worried, they say rule out intracranial hypotension. Always give contrast. But many a times they will come to you spontaneously, and if they come spontaneous, you will flare sequence, develop your eye on this, and then in your exam, ask for contrast. Other signs are given in your books, but this is another case of spontaneous intracranial. Sorry, there is a typo here. So this is not hypertension, this is hypotension. And this is what we call the sagging of the midbrain. Sagging of the midbrain, because there is no CSF around it, so it sags down. So another case, and look at this. If you do a CT scan of this, it will occur as if there is a subdural hematoma. But when you give contrast, then it appears that this is all congested dura. Can you describe this candidate 3?
Okay, so there is an extraaxial lesion predominantly in the parietotemporal region. It is causing bony destruction with a extracranial component to it. There is some thickening of the dura surrounding that lesion.
Excellent. So what is your conclusion?
I'm thinking of a dural metastases.
Very good. Well done. So this case was a metastasis from rhabdomyosarcoma in a young patient of 25 years. So first of all, if you see carefully, because this mistake has been done many a time, this is a very obvious case, but when in the exam, people see this, extraaxial dural thickening with this rat tail sign. Many a times candidates or students, they just call it, this is a meningioma. Look carefully what is happening to the scalp, to the skull. And you can actually see the T1 weighted sequence is the best sequence. This T1, so develop your eyes on T1 weighted sequence to look for marrow abnormalities. So look carefully and look at the diploic space. The diploic space is bright on T1, and you can see that in this case, it becomes black, and actually you can see it's some infiltrative lesion which goes into the scalp, which enhances. So the main thing is T1 weighted sequence. Okay, now I am going to introduce to you. I think what I'll do is I'll take a 5-minute break because it's already, I think, time for a break, and then we Right. Candidate 3, you are still with us, but here this is a teaching type of a case. Please remember, we were basically covering MR sequences. And during that sequences, we also were covering anatomy. So I went into the anatomy of the meninges, etc., showed you a few cases. Coming back to the FLAIR sequence, please remember that FLAIR sequence is the most what we call sensitive sequence to pick up white matter abnormalities. We know that, you know, MS, etc. But in infratentorial brain, T2 is a more sensitive sequence than FLAIR. This is a take-home point. Look at this case. This case was infarction of the cerebellum. That is not the point. The learning point here is, look at the T2. On T2, this is high signal. You can see, and on FLAIR, you can barely see anything. Please also remember that in CORD, we do not do FLAIR, right? We do T2s, but a STIR sequence now is also considered very sensitive, and in MS, studies have come out which tell us that STIR picks up the plaques very well. So this was something about the FLAIR sequence. From here, we come to a bit of anatomy, and I am going to spend maybe 5-7 minutes on this, but I am going to ask candidate 3, first of all, few questions. So candidate 3, are you with me?
Yeah.
Okay. What is this?
So it's a cis sequence in the axial sections. It's usually a heavily T2-weighted sequence, but it demonstrates anatomy, I think, slightly better with like nerves and stuff. You can see. I'm not too sure. I've not really used it in my daily practice, but this is all I know about it.
Okay. So which part of brain is this? You can, you know, pons or midbrain?
So this is pons.
So what is this structure which is going anteriorly?
Is it one of the trigeminal nerves? Is it coming through there?
Okay. So what is this? You are right. This is the trigeminal nerve.
Yeah.
What is this structure which has got CSF?
The Meckel's cave.
Right. And what is this structure? You see, I call it the flower, by the way, because it has got a flower. Don't call it a flower in your exam, but I call it a flower. So what is this flower?
Yeah, so the cochlea and the right ear.
Cochlea. Right?
Sorry, cochlea.
So what is this?
So this is a vestibular nerve, seventh cranial nerve. Yeah.
Vestibular nerve is 8th nerve.
Vestibular cochlea. Yeah.
And so what is this? You see this one is a thinner, slightly superior, but just partly visible to you, not wholly visible to you. And what is here?
It should be the nerve above, so it should be the 7th. That should be the 7th nerve, and the one below should be the 8th nerve. Is it?
Okay, very good. Well done. Okay, you can mute yourself, and candidate 4, you be with us now. Well done, candidate 3. Now, so right, candidate 4, can you hear me, please?
Yeah.
Okay, I'm still in a sort of a teaching mode, so I'll ask you questions as we go. Now, the anatomy of the IAM is extremely important for the exam. And I am also going to teach you this anatomy in the head and neck, where I'll teach you the temporal bone CT, which is extremely important. But having said that, here, if you see here, this is the pons. From the pons, 2 nerves are this is the what we call the vestibulocochlear nerve. So this is the cochlea, that flower which is anteriorly placed. This is the vestibule, which has got superior semicircular canal, lateral semicircular canal, and posterior semicircular canals. I'll teach you in the head and neck module. So from the vestibule, two nerves come into the IAM. This is superior vestibular and inferior vestibular nerve. Superior and inferior vestibular nerve. And from the cochlea, the nerve which comes into the IAM, or this nerve goes into the cochlea, is known as the cochlear nerve. Now here they join together and they are, this complex is known as vestibulocochlear nerve, eighth nerve. Now to add to that is the facial nerve. Now facial nerve in this diagram has been cut here. So you can see that it is at a superior, just at a superior level than the cochlea, just superior to the cochlea. This is the facial nerve. This is known as labyrinthine portion of the facial nerve. It goes anteriorly, and this is the geniculate ganglion, and then it goes posteriorly. This is the tympanic portion. We will again cover it in the head and neck module. Having said that, the CIS sequence is the key sequence to see the nerves, the cranial nerves in the basal cisterns. CIS sequence is a physics term, constructive interference in steady state. It's a Siemens term, because we use Siemens. I'm using it CIS, and other manufacturers have got their own names for this sequence. Having said that, what is it? It is a highly T2 weighted sequence which is high resolution. So CSF appears very bright, and vessels and nerves, they appear as a filling defect. Now CIS sequence anatomy is asked in the exam, and you have to know it very crisply and sharply. So this is the IAM, and these are the fourth nerves which we just covered, and this is the seventh nerve. This is the should I ask candidate 4, which nerve is this?
That's the cochlear nerve.
So what is this?
And this is the vestibular nerve.
And what is this? And what is this?
That's the facial nerve, the one that's on the top.
Let me orient you. If you see, this is cerebellum, and so cochlea is here, vestibule is posterior. So the posterior nerves, these two have to be which ones?
These two should be vestibular nerves, superior and inferior vestibular nerves.
Superior and inferior vestibular nerve. And anterior nerves have to be the cochlear nerve and the seventh nerve. Now you tell me which one will be at a higher level?
The facial would be at the higher level.
Excellent, well done. So now what we have concluded here, we have got 4 nerves, 7 nerve, 8 cochlear nerve, superior vestibular, inferior vestibular. We also have the formula of 7 up, coke down. So 7 up, coke down, superior and inferior. And this case, you see, look at this sequence. And one of my registrars, she got it in the exam. As the first, the examiner actually opened this. This is a sagittal oblique CIS sequence through the IAM. And this is the sequence which was opened in the exam. And what is the concept? This, first of all, orient yourself. What is this? This is the cerebellum. So this is the IAM, and you can see 4 dots. Now, candidate 4, you tell me, which nerve is this?
That's the 7th nerve.
One.
That's the cochlear nerve.
And this one?
The 2 on the behind are superior and inferior vestibular nerves.
Excellent. And you can see the same here. So I'm going to show you this case in what I call a PACS type of a format. I'm going to stop share and then I'll open another PowerPoint. So please remember, all of this what I am teaching you has been asked in the exam, and this is what they will point out what is what, right? So, candidate 4, is this projecting for you? This is 6.
Yeah, it is.
Okay, so I'll
Yes.
still be in a sort of a teaching mode. So let me go through it. Now, if you see here, this is the medulla. Now, anteriorly, this is the clivus and this is the petrous apex. All of this we'll cover in the head and neck. Now, this medulla is changing into pons. So here comes the pons. Now, I'm going superiorly, and as I go superiorly, you can see fifth nerve and fifth nerve coming out. And this fifth nerve goes into this CSF space, which is an exam space. Many times I've been asked in the exam, a meningioma going into it, and the question is that why is it causing trigeminal neuralgia? So you have to know this. Please remember the anatomy is that the fifth nerve goes here. There is what we call a Gazarian ganglion there, and then it divides into V1, V2, V3. We'll revisit that aspect later on. But let's go to the IAM. Now, if you see, now I have gone, now this is the cochlea. So I have gone inferiorly, and you can see this nerve going. On an axial slice, there will always be partial voluming. You are not very sure what is what, but you are sure that this goes into the cochlea. Then if you see there is a nerve going here, and you know what is what, you are not very sure on axial, but this goes posteriorly, and this is the vestibule, and this is the lateral semicircular canal and the superior and the posterior. Coming back, now this is cochlea. I'm going to go at a superior level. So at this level, you can see this 8th nerve here. Now as I'm going superiorly, you can see this nerve here, which goes here and then goes like this superiorly. So this is the facial nerve. Let's trace it backwards. So this is it. This is the facial nerve. This is the vestibulocochlear. And facial nerve, I'm just tracing the facial nerve once again, and it is at a superior level. All of these things can be asked in the exam. Also, please remember that this is the basilar artery. I am not, when we do trigeminal nerve imaging, any patient who has got trigeminal neuralgia, we do this sequence to see what we call neurovascular conflict. And here, where there are vessels, are they, abutting the nerve, are they compressing and things like that? That is beyond 2B. So I'm not going to teach you. That is, nobody is going to ask you. But if there is a tumor here, you should understand that there's the fifth nerve is here and this is the Meckel's cave. So this is on anatomy, on axial, which you have to know for your to be exact. Now, I am going to stop share and then go back to my original. So, candidate 4, can you see it now, my screen?
Yes, I can see your screen.
Yes, name the nerves, right? Correct? Okay.
Yeah, so
No,
first
that's
of all,
fine. Excuse me, I was just trying to make sure that you are seeing my PowerPoint. That's fine. Okay, now I'm going to ask you anatomy questions on this slice. This is a cis-sagittal sequence. Cis-sagittal, and now this is midline. This is the pituitary gland. So what is this? Let me go here. What is this?
That's the infundibulum.
Okay, from here till here, what do you call this?
Sulcus terminalis.
So this is what we call the floor of the third ventricle, right?
Okay.
Floor of the third ventricle, and also known as hypothalamus. And so I'll come back to hypothalamus, but posteriorly, what is here? What is this overall?
That's the tegmentum, and that's the tegmentum area, and there is an aqueduct of Sylvius there.
Excellent. So this is the midbrain, and this is the tectal plate, superior colliculus, inferior colliculus. What is this?
That's the pineal mammillary body, or
So mammillary body is sitting here.
it's just sorry, it's there. Yeah. So this is the pineal, I think.
Pineal gland. Very good, very good. And what is this?
That's the corpus callosum.
Okay, okay, well done. Now, if you see, let's revise the anatomy. So this is the pituitary gland, anterior pituitary, posterior pituitary. Then is the infundibulum. From here till here is the hypothalamus. Hypothalamus have got, the floor of the third ventricle has got a few structures. Some of them are not important for you because you cannot discriminate between them radiologically speaking. But some of the words you have to remember. So in the floor of the third ventricle, this infundibulum, then there is tuber cinereum. Tuber cinereum. This is part of the hypothalamus, but this word should be in your vocabulary because tuber cinereum hematoma, also known as hypothalamic hematoma, is an exam case, and I'll show you. And then there is anterior perforated substance, there is mammillary body, there is posterior perforated substance. These words are irrelevant. Mammillary body, of course, you can see. And then is the midbrain. Now you have to, when you are in an axial slice, you have to, sort of understand that when I am going through the midbrain, I am going through what we call the, so suppose the slice is going like this. So you have to keep thinking like this. This is the midbrain, and anteriorly is the suprasellar cistern. Suprasellar cistern, and you can see that the slice will go through the infundibulum and maybe the optic chiasma, etc. So posteriorly, if you see here, sorry, let me clear it. So posteriorly, if you see it, this was the tectal plate. This is the posterior commissure. This is the anterior commissure. This is the pineal gland, and this is the habenular commissure. This is the corpus callosum, splenium, and the body, and the genu and rostra. So this is the lamina terminalis. So this is the anatomy. Now, to add to this, this is the ventricular anatomy, and we can understand that this is the lateral ventricles, frontal horn, and then the body, then the trigone. This is the temporal horn. This is the occipital horn. Point to remember that trigone is quite a, in a craniocaudal dimension, it is at a higher level there is trigone, and at a lower level also there is trigone. If the slice goes like this, you will have body of the lateral ventricle, then you will have trigone. If the slice goes through here, then you might have a third ventricle anteriorly and maybe the occipital horn if it is visible. Now, two lateral ventricles, they go through the foramen of Monro, and this is that slit-like structure which is the third ventricle. And third ventricle has got recesses. This recess, if you see here, this is infundibulum. This recess goes inside. So this is the infundibular recess. And this recess, which is anteriorly, this is the chiasma. So this is the chiasmatic recess. And superior to the pineal is this recess. So, pineal is sitting here where I'm pointing out. Superior to that is the suprapineal recess. So on a cis sequence, actually, you can see all of this. So this is the pineal. You can see this suprapineal recess. This is the infundibular recess. This is the chiasmatic recess. This is the the floor of the third ventricle. And mammillary body is one structure. Otherwise, you can stretch your imagination, tuber cinereum, etc. Just call it hypothalamus. And this is the midbrain, the tactile plate, the colliculus, etc. This anatomy is important because when you know the tumors which we will cover, there will be a tumor which will be infundibular tumor. There will be a tumor which will be, let's say, hypothalamic, or here pineal gland tumor. So all of this anatomy is important for you to remember. This is a case of peptic aqueduct stenosis, in which there is hydrocephalus. You can see this upward bowing of corpus callosum. There is a cyst of the pineal also. So this is where the pineal is. Okay, a few exam tips on an axial slice. So ST4s, of course, you know the anatomy, but some of this anatomy I want to revise for the juniors who are listening. Axial anatomy tips for the exam. Now, please remember that CSF spaces are extremely important for you to remember. CSF spaces are within the ventricles, but we are talking about extraventricular CSF spaces. If we go superiorly, the CSF spaces haven't got any names. But you must, when you are doing a CT scan in the exam, you must go till the top. You might have some subarachnoid hemorrhage sitting at the last slice, and you will miss it. And you compare the CSF spaces right and left. That's the key for the exam. You might miss a subdural hematoma which is sitting up at the vertex. More inferiorly, there are names to what we call the basal cister, and this is the Sylvian fissure. But this slice is where a lot of action is. First of all, for orientation, it is a few key points for the exam you have to remember. If you see here, this is the pons and this is the midbrain. On an axial slice, the formula is, I call it the fat man. So pons has got this protuberant belly, and Mickey Mouse is the name of the midbrain. You can see that the Mickey Mouse has got ears here. So on an axial slice, when you are going through it, as soon as you see the Mickey Mouse, you know that I am at the level of midbrain. So that's the formula. More superiorly, if you see here, this is the level of the pineal gland. So what are the key features here? Slit-like, third ventricle, thalamus here. And at this level, posteriorly will be a pineal gland. In the exam, they have shown pineal gland tumors on axial CT initially. And you will only pick it up if you know these landmarks. So remember the landmark, thalamus, midbrain, posteriorly, not midbrain, third ventricle, posteriorly is pineal. Here, Mickey Mouse, and you are at the suprasellar cistern level. And here, fat man, and you are at the level of pons. Anterior to the pons, basilar artery, this must be your protocol. Please remember my words. In each and every case in the exam, this should be your checklist. Is there a thrombus sitting there or not? Particularly if the clinical is unconscious patient type of a thing. Thrombus in the basilar artery. Then this is one cistern which is known as prepontine cistern. This cistern is cerebellopontine angle cistern. Superior to that is the suprasellar cistern, where a lot of action is, and it has got many limbs which go to the Sylvian fissure. Optic chiasma, internal carotid artery divides into MCA, ACA here, aneurysms, etc. But here is the pons, the midbrain, the Mickey Mouse, and this cistern here is interpeduncular cistern. Interpeduncular cistern is an exam cistern because they will show you a case in the exam where subarachnoid hemorrhage is just sitting here, nowhere else, and you are going to miss it. Around this is the ambient cistern. This is the quadrigeminal cistern. This thing is known as the medial most portion of the temporal horn is known as uncus. And this is important. This concept is very important because this concept is going to be asked to you in transtentorial herniation, where this uncus actually goes through the hiatus, tentorial hiatus, and then compresses the midbrain. The posterior cerebellar artery, PCA, passes through the ambient cister. And that is why when there is transtentorial herniation, it can be compressed, and in an exam case, there will be an infarction of the occipital lobe. Infarctions can be on the same side, can also be on the contralateral side because this midbrain is going to be compressed. So if you don't know this anatomy, you are not going to pick that up. So coming back to the ventricles, and this is the point which I was making. Now, this is the frontal horn, this is the body, and this is the trigone. So here, this is the frontal horn, this is the body, and this is the trigone. Slightly inferiorly, frontal horn, foramen of Monro, third ventricle. Trigones are still there. So we are somewhere here. They are still there, and the occipital horns are usually not well seen unless the patient is very, has got an atrophic brain. And please remember that anatomy is very well seen on this case because I have selected a slightly atrophic old age brain. Otherwise, in a young patient, all of this will be difficult to pick up. Okay, this was for ST1s and ST2s. So those of you who are leaving, this is the QR code for the feedback. Before you go, if you can fill that up. Okay, now we will go into hemorrhage, signals of hemorrhage. So candidate 4.
So on this, first of all, I've got the PD PD sequence. On PD sequence, I've got hyperintense.
Excuse me, you are saying this is a PD sequence?
This is a flare sequence. Sorry.
What is the white matter?
White matter is white, so it's T1.
This is a T1 and this is a T2, right?
So
what is this? This is a hematoma. I want you to classify this hematoma. Tell me which type of hematoma is it?
So you want to whether it's acute or not?
So, sorry, what have I done? What did I do? Okay, now it's back. So, I want you to classify this hematoma. Do you know classification of hematoma on an MR? You know, on just like we did classification of infarction, hyperacute, acute, subacute, chronic.
So this well-defined hematoma, it is bright on T1 and it is dark. It's dark on T2. So this means that this is subacute hematoma. And
subacute hematomas are divided into early and late. Which one is it?
So this is early subacute hematoma.
Okay. Now, this is from your book, Causes of Low T2 Signal. The main point is, coming back, this is a continuity in the same, there is a chart also. This is from the latest edition. And phase of bleeding, hemoglobin breakdown, T1 signal, T2 signal. So hematomas can be divided into hyperacute, which is less than 1, acute 1 to 3, early subacute 3 to 7 days, late subacute 7 to 14 days, chronic is more than 14 days. And what happens is that initially hemoglobin is oxyhemoglobin, it changes to deoxyhemoglobin, and then it changes to methemoglobin and ultimately to hemosiderin. If you see the signal intensity, initially a T1 or T2 weighted sequence is not very sensitive because it will be low to ISO on T1 and high on T2. Acute hematoma can be low on T2, deoxyhemoglobin. Please remember, this is a take-home point for you. Deoxyhemoglobin can be low on T2, but on a T1 weighted sequence, it will still be ISO or low. Methemoglobin, as soon as it is converted to methemoglobin, it becomes bright. Early subacute hematoma is bright on T1 and low on T2. Late subacute hematoma, which is 7 to 14 days, high on T1 and high on T2. And then when it becomes hemosiderine, it is low on T2. So point to remember, in the exam, they will ask you subacute hematoma, which will be bright on T1, and then on the basis of T2, you can classify it. And methemoglobin, they say, is the brightest thing on a T1 weighted sequence in the human body. But you can take it with a pinch of salt. At times I felt that it is not as bright as fat. Please remember the conventions. Few things which I want to highlight is that this chart is for intraparenchymal hematomas, and it depends on oxygen tension. So if there is a subdural hematoma or let's say extradural hematoma, it might take more time to change. Number two is, convention is that if a hematoma has got various types of components, it is classified by the most oldest component. So if a hematoma has got a chronic component, and with that there is a subacute component, you will say that there is a chronic hematoma with a portion which is subacute. And another thing which I have already pointed out, take home point, is that subacute hematoma is the only type of hematoma which is bright on T1 weighted sequence. Okay, candidate 4. What is this?
So I'm seeing that there is hyperintensity on the T1 weighted sequence, and that is all of tracking all along the right convexity and also within the FOX.
Right. So conclusion.
So this is bright on T1. So I'm thinking that this is hematoma that is tracking along there, and it will be early subacute.
Okay, you cannot. You see, the point is that early subacute, you can say it is a subacute because it is bright on T1, but for characterization early and late, you have to see a T2 weighted sequence, right? Yeah. So this is the T2, this one. So what is your
conclusion? So on T2 it is dark and it's bright on T1, so it is early subacute.
Okay, so this is a subdural hematoma, and you can see it did not cross the FOX. It goes into the subdural, bright on T1, low on T2. Okay, this one is bright on T1 and bright on T2. Over to you. What do you think?
So bright on both, so it would be late subacute.
Excellent. So now what is this one?
So this would be bright on T1 and low on T2, so it will be early subacute.
Excellent. Now, this one, on the other hand, is, don't confuse yourself with the central portion, which is a bit of cerebromalacia, cystic cerebromalacia. It is sort of iso-intense on T1 and low on T2. So, what do you think?
So, I'm thinking that it has got a mixed signal, and we've been told that to characterize with the oldest signal. So I'm seeing that there are some portions which are dark on both T2 and T1. So it is likely to be a chronic hematoma with subacute component to it as well.
Okay. You see, the thing which is confusing you is that on T1 weighted sequence, there is actually, this thing is a bit of cystic cerebromalacia. When there is, and which is CSF intensity. And part of it is slightly confusing. But the main point is that this is hemosiderine, which is low in signal intensity. Now, I am going to introduce to you another sequence, which is known as T2 star sequence, which is this one. What do you know about this sequence, T2 star?
So T2 star, I know, is if there is any hemosiderin or any paramagnetic substance that would cause the blooming artifact. So you'll get a sharp decline in the signal. So it will be very black, like the. So if there is any hemorrhage, you can easily pick it. Tiny microhemorrhages are picked with T2 star.
Okay, thank you, candidate 4. Candidate 5, are you with us? Candidate 5, are you with us? Yeah.
Hello?
Okay. So, if you see, okay, candidate 5, welcome. Please stay with us. Now, if you see, this is a T2 star sequence, and what is a T2 star sequence? This is a susceptibility weighted sequence. The physics is different. And previously we used to do a T2 star sequence. Now we do what we call an SWI also. It all depends which scanner you are using. T2 star is the most sensitive imaging tool to pick up hematomas. Basically, the physics is that if the magnetic properties of a substance are drastically different than the surrounding brain parenchyma in the as far as brain is concerned, then on this sequence it gives there is a signal loss, it gives a signal dropout. We call it a blooming artifact, and it appears very black. Now, if you see here, there are small micro hemorrhages, and which are barely visible on T2 and not visible on T1. So this is the only sequence on which they were visible. Now, candidate 5. I am showing you this T2 star sequence in a case. The patient's age is 69. What are your findings, and what is your differential for this?
So on the selected axial images, I can see that there are multiple foci of low signal scattered throughout the pons, as well as both cerebral cortices. In a patient of this age, I'd be suspicious of small microhemorrhages, possibly related to cerebral amyloid angiopathy. If there's a history indicating any sign of infection, these could also be small septic emboli.
Okay, other than in this age group, other than cerebral amyloid angiopathy, anything else which is more common than septic emboli, that this patient was clinically not septic?
Small hypertensive microhemorrhages.
Excellent. So if you see this microhemorrhages on MRI, this is important because and this is very important for your day-to-day clinical practice. T2 star or SWI sequence should be part of the protocol in any patient which is 60 plus age group. Why? Because of cerebral amyloid angiopathy. In our department, we do it as a standard now. It is, each and every patient gets it. Cerebral amyloid angiopathy is only diagnosed because of microhemorrhages. So the patient will have microhemorrhage. They will only be picked up if you do a T2 star or SWI sequence. In hypertensive encephalopathy also can cause this. Of course, the clinical will be different. And usually in cerebral amyloid angiopathy, the microhemorrhages are more peripheral subcortical. Here, they are more central, basal ganglia, thalami, and things like that. Now, in trauma, microhemorrhages can be because of diffuse axonal injury. In a younger age group, always remember cavernomas. Cavernomas are very important for the exam, also known as cavernous angiomas. So we'll cover them subsequently. But many other things like hemorrhagic metastasis, sickle cell anemia, which, because of fat emboli, etc. Fat emboli is again given here also, can cause microhemorrhages. And you can well imagine that this patient will, can come as a long case also. Something in the brain, and with that some stigmata of sickle cell in another part of the body. So septic emboli, of course, is an exam case which you have already mentioned. So this is a case of cerebral amyloid angiopathy, and you can see these innumerable number of microhemorrhages. SWI sequence, the physics is different, and the vessels, the vein, they also appear as low signal. So this is the SWI sequence, and this is a T2 star sequence. Basic use is the same. You can use the word susceptibility weighted image to cover yourself, and you are not wrong. Is there any hemorrhage in the ventricle? Candidate 5, this patient had intraventricular hemorrhage. So right now, is there evidence of any hemorrhage?
On the susceptibility weighted images, it does look like there's some low signal in the lateral ventricles and the occipital horns, but this is of similar signal to the choroid plexi. In a 2-month-old patient, I don't think this is going to be calcification, so I'm inclined to say yes.
Okay, so if you see here, there appears to be on this T2 weighted sequence a sort of a level type of a thing here. And then on this SWI, you can see this low signal. So, it is in the dependent portion. So hemosiderin sitting there, which is not visible on other sequences. Okay, this is a classical exam case. T2 weighted sequence, T1 weighted sequence. What is over to you, please.
Right, so there's an abnormality in the corpus callosum, sort of straddling across both sides, which contains on the T2 images a low signal intensity rim with foci of high signal in the middle. On the T1, there are corresponding areas of high signal in the periphery of the lesion. The peripheral low T2 signal makes me think that this could be a cavernoma in the corpus callosum.
Excellent. Excellent. I'll take over because of the time factor. Well done. So you see here, this is a classical exam case. Cavernomas are, have got various kinds of appearances. Cavernomas can occur in this location, which is the geno of the corpus callosum. It is going from one hemisphere to another. Key finding is this hemosiderin rim. If you see this, there is a T2 weighted rim, and which is chronic hemorrhage. Within that, there are foci which are of different signal, as in subacute hemorrhage type of. But that appearance is also known as popcorn appearance. So this is classical for a cavernoma. A complete hemosiderin rim, they say, will not occur in a tumor. So this is a classical cavernoma, and this is an exam case. Okay, this case is your last case, candidate 5. This patient had history of trauma 21 days ago, had a small subdural hematoma on right side, still is having neurological symptoms. A CT scan was done. The hematoma, the subdural hematoma is barely visible, but the patient was not well, and MR was done. What are your findings? Now here the subdural is visible. This is an SWI sequence. What are your findings now?
Okay, so there is a low signal lesion in the, I think it's the left frontal lobe. There's also prominence of the left lateral ventricle that may be related to the way the slices are taken. There's also another small focus of high signal in the superior right frontal lobe.
Okay, so we can see this low signal here, maybe here, another one here, another one here. With this history, what is your diagnosis?
I think in the context of trauma, could these be small traumatic microhemorrhages?
So what is which kind of history the patient had, which can explain the symptoms also, neurology? These hemorrhages or microhemorrhages are at the gray-white matter junction. That is the hint.
So a diffuse axonal injury type picture.
Excellent, excellent. So thank you, candidate 5. So this is the use of SWI sequence to diagnose diffuse axonal injury. We'll cover diffuse axonal injury later on. But having said that, please remember that this is one of the primary brain injuries. Only 2 types of injuries can occur at the time of the trauma. Parenchymal injuries can occur. One is known as contusion and second is diffuse axonal injury. Usually on a CT scan, we don't see it. And clinically speaking, the patient might be much worse off. Diffuse axonal injuries, you have to know that they are at a particular location. What is the location? By the way, the list is more than what I am telling you, but the 4 most common locations are gray-white matter junction, corpus callosum, internal capsule, midbrain. But there can be others also. And you have to see, petechial hemorrhages on a CT scan. But diffuse axonal injury usually is not that. Diagnosed on CT scan, do an MR, you do those. Now, this case, I am just showing you for interest, and I'm not going to teach you. I believe it's a bit beyond FRCR2B. A theoretical question can arise is about SWI sequence, where please remember, compounds causing susceptibility include all of these things: hemorrhage, as well as iron, as well as hemosiderin. Deoxyhemoglobin is acute hemorrhage, minerals, and calcification. So the question is, can we differentiate between calcification and hemorrhage on SWI sequence? And the answer is yes. A poor man method, by the way, is that in your day-to-day practice, you simply see the CT scan. If there is calcification, you call it calcification. But you have to do this filtered phase image. A bit of physics is involved. When you do an SWI sequence, you can post-process them into various kinds of sequences: magnitude, filtered phase, SWI, combined post-processed magnitude and phase, and SWI minimum intensity projection. Out of this, filtered phase will give you this kind of an image. And basically, you have to develop your eyes on your own scanner because it's very complex. Physics is complex, and then windowing and inversion of images and things like that. That is why I say it is beyond FRCR2B. But if the examiner asks you, at least you should know this theoretical answer, that yes, a filtered phase image can be used to differentiate between calcification and hemorrhage on a susceptibility weighted image. And in the same breath, but there are many pitfalls also. Another take-home point is that on susceptibility image, weighted image, deoxyhemoglobin, which is an acute hemorrhage which occurs only after 1 day, deoxy can be picked up. So you can pick up 1 day old hemorrhages. Okay, we stop here, and next will be we'll take a 5-minute break, and then we'll go to candidate number 6 after the break. And I can see.
Yes, sir.
Okay, you are there. Okay. So this case, I'm just going to tackle it myself. Sometimes what happens is that there is a condition, we call it siderosis, where what happens is that when a patient has got chronic subarachnoid hemorrhage, maybe post-traumatic at times because of vascular malformations, or even at times tumors, then this goes and deposits on the leptomeninges, and when it gets deposited on the leptomeninges, usually in the basal cistern, around cerebellum, bones, etc., and in this case also on the spine, and you can see how it is low signal on T2 weighted sequence. And another case here is where you can see on this SWI sequence all of this deposited there. The problem is that this is quite neurotoxic, and it gets deposited on the cranial nerves also. For example, the 8 nerves which are in the basal cisterns, and the patient will present to you with deafness, etc. So the point is that I just wanted to show you another use of the SWI sequence. We call it superficial siderosis, and this has now been included in the Chapman superficial siderosis. And so, previous subarachnoid hemorrhage is something which, if you remember this is enough, which can be due to vascular malformation, CNS tumors, etc. Okay, this is a case in which patient presented with hemorrhage, subarachnoid hemorrhage, 6 days ago. After 6 days, CT was done, and this flare sequence of MR was also done. What are your findings? How do you explain this? Over to candidate 6.
So I can see the non-contrast axial CTs, but I can't see any acute intracranial bleed or subarachnoid blood. Looking through the flare sequences on the 3rd and 4th images, I can see there's some high flare signal in the subarachnoid space and in the central sulcus on the 4th slice. But I've got no other sequences to correlate. But
so how do you explain this finding on the flare? What is your interpretation of this finding?
So I'm suspicious of a but I can't see any concurrent finding on the CT to explain this could be subarachnoid blood, because I should be seeing it on the CT and not.
This case. I warn you that the scenario is slightly atypical, but this film is an exam film. The scenario is atypical, and you have to understand, once you pick up this finding, what can be the causes. Indirectly, I'm asking, if you pick up high signal within the sulci on a flare, what can be the cause?
Subarachnoid would be my top differential, but because I've got the CT head from the same day, but it might be because I'm not seeing it because it's day 6, it's not acute, so I'm not seeing the subarachnoid blood on the CT, whereas for this day 6 or for a flare, for blood on a flare should be bright.
Right. Okay, so the point is that this is from your Chapman, sulcal flare hyperintensity. And hyperintensity means, on a flare sequence, basically, please remember that the CSF has to be, black. And then you get this high signal. So something is abnormal. Subarachnoid hemorrhage is one of the differential. In this particular case, the explanation is that there was a bit of subarachnoid which is no more visible because it is 6 days old and it is a bit diluted. Having said that, other things which can leptomeningeal carcinomatosis or any infective process can also cause this, and you have to remember this. And if you pick it up, then you give contrast to rule out any enhancement. And so, for example, this was a CT scan where you can see, this subarachnoid, which is high signal on FLAIR. But look at this case. This case on a T1 weighted sequence, there is no enhancement, but on a post-contrast sequence, you can see this enhancement. And if you look at the FLAIR, you can see this high signal, just like the previous case, which I was showing you. And actually, this was a case of esophageal carcinoma. And with this finding, what will be your conclusion, candidate 6?
So with this finding, it would be in pachymeningeal carcinomatosis.
Leptomeningeal means,
So it means
it goes gyriform or, along the folia. So it has to be leptomeningeal.
Yeah.
Right? So please remember, the main thing which we were learning here is high signal on the FLAIR. So this is, once you pick it up, you give contrast, and if it enhances, your differential has to be something bad, infection or tumor carcinomatosis. Okay, the final differential diagnosis of this is this one. So what is happening? There is a tumor in the ventricle. It is sitting within the ventricle, this tumor. What is this signal where I am pointing out this bright signal?
So the bright signal on the FLAIR stays bright.
Is it FLAIR?
No, sorry, on the T1 is bright. On the T1 the T1 coronal, and so it's bright on T1. So my differentials for bright on T1 would be subacute, early subacute blood, fat, mucin, but this doesn't look like a lipoma. This looks like a tumor with some blood products in it.
Okay, so you're fine. It is a tumor with something inside, but it is not blood product. It is not fat. What else can it be?
Melanin?
Good thought, but no is the answer.
So bright on T1 is fat, melanin, mucin, blood. Those are the four I know of.
Okay, so the idea was, do you see the CT scan?
Yeah.
So what is the answer now? Calcification.
Okay.
So the teaching point here is that there is a particular type of calcification which can be high signal on T1. So this is the list from your latest edition, and everything which you pointed out is fine. Fat, methemoglobin, proteinaceous matter, melanin, minerals. Calcification is what I was trying to show you. So please do not think that all kinds of calcification will be bright on T1, but the only thing to remember is that some types of calcification can be bright on T1. This is another case. In this case, there was what we call a burnt out AVM. Burnt out is partially calcified. And on susceptibility weighted image, there is a signal loss here. And correlating with this finding or this finding, you can see that portion of it is bright. So that was the point to remember on this. You might have seen Fox calcification so often on a CT scan. And point to remember is that at times that can also be bright on T1 weighted sequence. You see this T1 and it is bright. So, and sometimes calcification can be very tricky. This one is high in signal intensity on T1 as well as T2 weighted sequence. If you see here, this is bright on T1 and bright on T2. You don't have to, should I say, your confidence should not be shattered. Calcification usually is low signal on T1 and T2 weighted sequence. But the point to remember is that at times it can be bright on T1 weighted sequence. This is your last case, and then candidate 7 should be ready. Candidate 6, what is it? Which sequence is this?
So on the top, I've got a axial slices of a T1 with contrast. And on the sagittals, I've again got T1.
Okay. Question mark.
No, I think it's a pattern of a disease. It's not contrast.
Yeah, if you see nothing is enhancing, you know, pituitary, nasal mucosa, no vessels, no nothing. So the point is it was not enhancing.
So I've got I can see there's a disease pattern mainly involves so it's going through the gyri, and it's a gyriform pattern, high intensity. And
let me give you a hint. It's sitting in the subarachnoid spaces.
So again, this could be blood.
Blood will never be, you know, the intensity, a 3-day-old subarachnoid will never survive like this, you know. So, no, because it will be very diluted by that time.
This could be calcification.
No. So now you know the answer. This is, now I had hidden part of the findings on those sequences. Now I've added that part. Now what is your diagnosis then?
So we've got an extra axial bright on T1 with some low signal intensity within it. Looks like fat to me.
So confusion.
A lipoma?
How do you
dermoid, sorry, a dermoid.
And what has happened to the dermoid?
So it has ruptured.
Yes. Okay. You can mute yourself, candidate 7 to be ready. Let me tell you the teaching points. Now, the point is here, I just selected some images just for you to stretch your imagination. I had not shown you everything intentionally. Ruptured dermoid, if you see here, this is a ruptured dermoid. So on this is fat, and a fat saturated sequence, it shows signal dropout. Please remember, how do you differentiate a lipoma from a dermoid? You know, pathology gives you radiology. Lipoma is all fat. It will be 100% fatty signal. Lipomas are considered choristoma, as in a hematoma, you know, just like a hematoma in the chest. So it's a normal tissue at an abnormal location. Dermoid also, on the other hand, pathologically speaking, dermoid will have multiple layers, you know, dermis and subcutaneous fat and all those things. So the signal will be slightly heterogeneous. It will not be absolute homogeneous fat. just like our case, there is something else also sitting in. Please remember the concept that dermoids enlarge. They are not neoplasia, but because they are, genetically tuned to grow. So, and that is why they can rupture. When they rupture, now ruptured dermoid is an extremely important exam case. It has come in the exam many a times. And please remember the dermoid might be sitting in the brain and the dermoid might be sitting in the spine. So they will show you a CT scan in which there will be fat within the CSF, and you have to do your densitometry where it will be lower signal than CSF. I've got cases I'll show you later on. And then the examiner, because on the CT you will not see anything, then the question will be what you will do next. Actually, you should yourself ask that I will like to scan or I'll like to see the images of the spine. And there will be the ruptured dermoid sitting. So please also remember that ruptured dermoid is such a condition that it causes chemical meningitis, and 30% is the mortality. This is where a benign condition can kill a young person. So this is a ruptured dermoid. Now this is a lipoma, and this lipoma is sitting around the corpus callosum. The idea was just to show you this high signal on T1 weighted sequence. So lipoma of the corpus callosum, particularly with agenesis of corpus callosum, that also comes in the exam. Particularly, they might start with a CT scan, axial slice, and then take it further. So I'll show you cases later on. This is a lipoma which is sitting in the quadrigeminal system posterior to the midbrain. So just wanted to show you that, you might pick it up. You might see a lipoma sitting in the suprasellar system. Just call it, and it is of no significance. But if there are heterogeneous signal within a lesion, consider it a dermoid. Dermoids are more commonly in the midline. Okay, candidate 7, are you with us?
Yes.
Okay, now candidate 7. If you see here, this is a T1 weighted sequence. This is a post-contrast T1. This is a T2 weighted sequence. Now, what is this, which is also seen here?
This is sphenoid sinus mucosal that it's written.
Excellent, well done. So this is a sphenoid sinus mucosal. If you see the sphenoid sinus is expanded, and because of high proteinaceous content, it is high signal on T1 weighted sequence. Please remember the list in which, in the list of high signal, the proteinaceous material. Similarly, high signal can be in things like colloid, cyst, etc. Last case. Because this was referred by a dermatologist, so you cannot make a diagnosis just on this basis, but how will you describe it?
There is T1, initially hyperintense intraaxial lesions noted at the both cerebral hemispheres. Since it's referred by dermatologist, I could consider melanoma metastasis.
Okay, so it can be melanomas, it can be, one can argue that it might be hemorrhagic metastasis. And what happens is that within hemorrhagic metastasis, there can be, melanoma can also cause hemorrhagic metastasis. So I am going to show you a case which is a CT scan. Unfortunately, I don't have a pre-contrast for this patient, but there are a few learning points on this case. This patient presented with a lot of neurology, and patient was a known case of melanoma. So we did a pre-contrast as well as contrast. I don't have the pre-contrast with me. Having said that, if you see here, there is something happening here, and there is, on a CT scan, there is a bit of leptomeningeal enhancement here. Leptomeningeal enhancement on a CT scan is difficult to pick up than an MR. Then there is some edema here, and one can argue that there is a bit of enhancement in this region also. So these are the findings. Now on a T2 weighted sequence, you can see a lot of edema, and then you can see edema at other location. Now concentrate on this region where there was leptomeningeal enhancement on the CT scan, particularly here. And then we go to a flare, and it tells you quite a few things happening right and left, which were not seen on other, sequences. And then we go to a T1. Now this T1, if you can concentrate on this T1, you can see, look here, there is a deposit sitting here, which is high signal. So this is that melanoma, and then there is surrounding edema. Again here, and here, and again here, and again here. So these are melanoma metastasis, and then on contrast, a lot of enhancement around it, and leptomeningeal and things like that. So this was on a coronal sequence. How does it look like, and how it is going into the various. Now this is a good one just to develop your eyes, where you can see this leptomeningeal enhancement. Leptomeningeal, another deposit sitting here. So, and on a sagittal, you can see, look at this one. It goes along the gyrus, and then enhancement goes into the subcortical region also. Again, here also. And again here. Okay. So these will be the next sessions. Thursday, 13th August, we start at 5:30 actually, 3.5, and then just Saturday, 15th August, 5 hours. Okay, look at this optic nerve and this optic nerve, and what is your diagnosis?
The optic nerve is seen on the right side, is seen enlarged. I think this is meningioma affecting the optic nerve, because I could see on the coronal images that there is a like a donut sign.
What would you like to do?
I would confirm it with the post-contrast study.
So on post-contrast, there was no enhancement. I don't have post-contrast, but there was no enhancement.
Still, because I could see the optic nerve could delineated, this still could be meningioma.
What else can it be? You know, meningiomas will enhance, right?
Yeah. Glioma is less likely because the optic nerve is seen. Could be sarcoid. Other possibilities.
Okay, thank you. Sorry, I don't have time to give you more cases. I've got 2 more candidates. So thank you very much, candidate 7. Candidate 8, if you can raise your hand. Now, let me do a bit of teaching here. We are candidate 8, are you with us? Okay, candidate 9.
Hello?
Okay. Actually, candidate 8 is also with us, okay?
Yeah.
Okay, candidate 8. Now, I'm going into a teaching mode once again. Now we have started a section. You know, till now what we have covered is just miscellaneous type of things in CNS. It's a mix and match what we covered today. It was a bit of anatomy, it was a bit of signals, it was a bit of sequences on MR. And we have covered, how do you diagnose which kind of sequences in the exam, what are the basic sequences. We did a few differential diagnoses, which were, leptomeningeal or Pecci enhancement, microhemorrhages, siderosis, etc. Now the main curriculum is starting actually. So now we will go, in a more, should I say, structured manner. And the things which we have covered today, they will help you. As I've told you, that the first two, sessions, I will go slow. So I intentionally went slow today, particularly so that the young generation, the juniors, they can also get something out of it. So now this is where we are starting curriculum. Of course, we will stop today and then we'll continue next time. Now the teaching point here is we are into phakomatosis. Phakomatosis, if you ask me, what is the most important subject in the FRCR2B CNS, it's phakomatosis. More cases come from it than anything else. Some of these aren't many cases which, at times they don't like to show nowadays. Having said that, you must know them. Now, phakomatosis NF1, NF2, von Hippel-Lindau syndrome, tuberous sclerosis, and Sturge-Weber syndrome. There are other things also, but these, the ones which I have mentioned, are extremely important. NF1 is the most important. And in NF1, there is a criteria to diagnose NF1, which we will consider. But in NF1, what happens is that optic nerve glioma, that's one of the prerequisites. The teaching point here on this case was to develop your eyes on a sagittal sequence. This is the optic nerve. This is the optic nerve. If you see this optic nerve is thickened and it is slightly tortuous, and this is straight. They say that even if you see a difference of about 2 millimeter with the clinical context, you can call it an optic nerve glioma. Now, optic nerve glioma is a low-grade tumor. So, in a child, it is always low-grade. And if you go back to the basics about brain tumors, please remember that we grade them into grade 1, grade 2, grade 3, grade 4, according to WHO criteria. By the way, this WHO criteria was revised in 2016 with immunohistochemical criteria, which in our practice we don't use it, but we are still sticking with the old concept, grade 1, 2, 3, 4. Now, grade 1 tumors are less malignant and grade 4 are the worst of, the GBM. There is a concept in CNS tumors of upgradation of a tumor with time. So a tumor can become from grade 1 to grade 2 to grade 3 and then grade 4 over a span of time. Optic nerve gliomas are grade 1 tumors, particularly in children in the context of NF1, but in adults they might be grade 3 or even 4. So grade 1 tumor might not enhance. That's a take-home point. At times they will not enhance. Another thing which can be asked in the exam is this appearance on a coronal sequence, where you can see this optic nerve and you compare it with this optic nerve, and of course it's not completely symmetrical, but this optic nerve is larger as compared to left. It's a subtle finding. This case is a difficult case, but I just put it for teaching purposes. Once you see this, you will pick up more, blatant type of cases. Now, phakomatosis has got, this is from your old Chapman, where phakomatosis is, this is the 6th edition, NF1, NF2, tuberous sclerosis, Sturge-Weber, von Hippel-Lindau, hereditary hemorrhagic telangiectasia, etc., and Sturge-Weber. But in the new Chapman, if you go to the second part, you will see. If you go to the second part, you will see, sort of a summary of NF1, etc., and von Hippel, etc. So in the second part, it is given. Actually, if you go into details, then from there you can make long cases where you know that in NF1 what happens in skull versus what happens in abdomen. The examiner might give you a long case out of this. So this is the importance of phakomatosis. Long cases can come in the exam because of that. Okay. Now, what is the criteria to diagnose NF1? If you open a textbook and see the clinical definition of NF1, they say that if the patient has got 2 or more than 2 of the following, then you call it NF1. And K-Foulée spot, 6 or more, 5 millimeter, axillary freckles, Lisch nodules, which are iris hematomas, first degree relative with NF1. Look at this. All of this is clinical, nothing to do with radiology, and we are not interested. The clinician will tell us that the patient is suspected NF1. But here we are interested because this is all radiology. So what is in the definition? Neurofibromas, 2 or more than 2, or a plexiform neurofibroma. Then optic nerve glioma is part of the definition. And then distinctive bone dysplasia, which include bare orbits, dural ectasia, and pseudoarthrosis. So with this background, let's see the type of cases which can come in the exam. So candidate, okay, sorry, still in a teaching mode. Optic nerve glioma can occur all the way, it can go all the way to the optic radiations here. So, this is optic nerve, optic chiasma, optic tract, and then it can go all the way, and this you have to understand. Okay, this is a case of NF1, candidate 8. You tell me the findings, please.
There are it's bilateral thickening of both optic nerves. So sorry, these are T1 sequences.
Yeah, that's fine.
So I've got both coronal and axial cysts, and there's bilateral thickening and kinking of the optic nerve, on most prominent on the axial slices through, which makes me suspect that there's bilateral optic nerve gliomas.
Okay, very good. If you see here, on an axial slice, so examiner is going to show you on axial, right? Mm-hmm. And you can see this, it goes into the optic chiasma, it goes slightly. Now on this one, if you can see, there is a bit of high signal on this T2. If you compare it here on the post contrast, it goes to the lateral geniculate body, which is next to the thalamus. So the point here which I'm making is that it can go backwards, right? Now look at this case where
left optic.
So just on this, you have picked up this. Very good.
Wow.
Now what?
So it's gone backwards.
So, anatomy-wise, where are we sitting?
That's the so that's, it looks like the basilas, and so you've got the ICAs inferiorly.
Yeah, very good. So the pituitary is here, so we are superior to the pituitary, right?
Yeah.
So means optic chiasma.
Yeah.
Agree?
Yeah.
Now, please remember, they are going to show you here, they are going to begin with axial. And this axial looks tricky, isn't it? That there is a mass here and you cannot make out where is this mass. Basically, if you go back to your anatomy and see this is the midbrain level, so the mass is sitting anterior to that, suprasellar, but here it becomes more obvious that where it is. Now, optic nerve glioma, this type of an optic nerve glioma has been shown in the exam, and my experience is that people have confused it because they have not seen in their clinical practice. So, just 1 second, please. I don't know if I'm able to show it to you, or can you see an image, or you're not able to see anything?
I can just see your files.
No, okay. Mass here, and then this is a lot of hydrocephalus. A lot of hydrocephalus is there. So what is happening now? This is sagittal. I'm going to skip this intentionally. Show you a coronal. Now, if you see here, look at this optic nerve versus this optic nerve. Both of them are so thickened, and this is that optic chiasma. And then you can see that the tumor goes along the optic tracts and on the left side maybe to the radiation. This is a flare sequence which you can see, and then the optic chiasma, and you can see how it goes posteriorly. So if you don't see it, you will be absolutely, you know, what is happening. So that's why I wanted to show it to you. So, supratentorial tumors in children and optic nerve glioma is one of the list. Can you see my PowerPoint now?
Yeah.
Okay, you know, because of time factor, sorry, I got, you know, because there was too much teaching today, I think I could not give enough chance to everybody of you. Can I go to candidate 9 who is still waiting?
Hello.
Okay, now this case, what is happening here, 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 here? The clinical history is that they are worried about NF1.
So there are selected axial MR sequences, and the obvious abnormality is high flare intensity foci located in the right lentiform nucleus in the midbrain and also in the cerebellum bilaterally. In the context of neurofibromatosis, I would be concerned that these represent focal areas of signal intensity, otherwise known as UBOs, unidentified bright objects, which I think are hematomatous lesions. But I would like to assess the rest of the neural axis for features of phacomatoses.
How will you do the scan?
Sorry?
Technique-wise, you know, whole of the neural axis, with contrast, without contrast?
I don't think contrast would be necessary to identify them. I would look on flare supratentorally and T2 in the spine and posterior fossa.
Okay. Right. Now, this is a very important concept, and this comes in the exam so often, and a few Viva questions which are for the exam in NF cases. What happens is that this finding is seen in many cases of NF, though it is not among the diagnostic criteria. Basically, what you see is that there are high signal within various parts of the brain. Which parts? Anything. For example, brainstem, pons, midbrain, cerebellum, basal ganglia, internal capsule, thalamus, white matter. There can be high signal foci like this in the midbrain, like this in the cerebellum. So previously these were known as UBOs, unidentified bright objects, or unidentified neurofibromatosis objects. Now we call it FASI, which is focal area of signal intensity, FASI in capital. The concept is that these grow in number and size till the age of 10. And after the age of 10, they start decreasing and they might just vanish after 20 years or so. The concept is that if they start increasing after the age of 10, we raise the issue of malignant transformation. This also tells you that FASI by definition is not as simple as hematomas. This was one of the concepts, but it's controversial because other people think that this is dysplasia, myelin vacuolization, or with potential of malignant transformation. So if they increase in size and number after 10, or you give contrast, and if they enhance, then you call it malignant transformation. So that will be a glioma then developing. So in the Viva, whenever you get a case of NF1 or NF2, you must say that I want to scan whole of the neural axis with contrast. Please remember, things like neurofibromas of the spine, etc., you might miss it without contrast. So that's a key point. And the examiner might show you if wants to show anything to you. Another thing is that these patients, as far as FASI is concerned, you want to monitor them. So after the age of 10, usually various people have got their own protocols, but usually 1 year follow-up scans are asked and with contrast for the reason which I have told you. Yes, please. Candidate 9.
We have axial.
So I will, because of time factor, let me tell you the sequences. Flare, T1, and T1, and this is post-contrast T1. So just concentrate here and here. And what do you think is happening?
So in this patient who is a known case of neurofibromatosis, there are bilateral enlargement of the optic nerves, including the chiasmatic region. This does not show contrast enhancement. However, there's a lesion more posteriorly in the paramidline right cerebellum.
That's fine. So this is the type of case you are expecting in the exam, where then you call it that this is malignant transformation. Okay. What about this orbit? Normal, abnormal?
Abnormal.
So what is the abnormality?
So I think the abnormality is on the left. I can't see the innominate line, which makes me concerned for sphenoid wing dysplasia.
Yeah, so if you see here, this orbit is larger, and in old books there was a differential diagnosis of enlarged orbit, by the way. This is normal. If you see, this is the innominate line, which is the lesser wing and the greater wing of sphenoid here. You don't see it. And this orbit is enlarged. That line is missing. This is the appearance which is known as candidate 9.
Bare orbit.
Bare orbit, as in naked orbit. So, and this is normal anatomy of what we were considering. And this is normal on a PA film that line is missing here. And this is another case of sphenoid wing dysplasia, where you can see that this is missing. And so, fine. What do you think is happening? We are given the diagnosis.
So there's tibial and fibular pseudoarthrosis formation with lucent lesions of the bone, which I think in NF1 are classified as non-ossifying fibromas.
So this is a classical appearance of, we have covered this in our MSK module. This is pseudoarthrosis. If you see, look at this, you know, in NF1, what happens is that there are bone dysplasias. This can happen in tibia, fibula, humerus. Sorry, correction, radius. I've shown you cases, appearance. It's an Aunt Minnie type of appearance. Nothing else can show you or can give you this kind of appearance. Of course, post-trauma, etc. is a different world, but post-infection is a different world. Clinically also, that will be different. So this is bone dysplasia, which can come as a long case also. What is this?
So just on the lateral film, we've got a scoliotic spine with a fixation rod in situ, and there's posterior vertebral scalloping and gross enlargement of the vertebral neural foramen. I think this is consistent with dural ectasia, or possibly a neurally derived tumor causing expansion.
Okay, so this we have done in our MSK module, and the idea was to repeat it or revise it. This is posterior scalloping of vertebral bodies. With this scalloping, there is also scoliosis, and both of these things go together. Posterior scalloping is usually due to dural ectasia. You are absolutely right that there might be some tumor also sitting with it. So this is a case where dural ectasia can be seen incidentally. The take-home point here is that it might be an incidental finding on a CT scan. If you see it, you are not very, oh, something is happening. Is there a tumor sitting there? You do an MR and it is just CSF. So this is dural ectasia and there is no tumor sitting in it. Yes, please. Last 2 or 3 cases, I want to finish NF1.
So we've got coronal, sagittal, and axial MR sequences of a 28-year-old male focused on the lumbar, spine, and pelvis. There is a gross abnormality consisting of lobulated high T2 signal soft tissue which is surrounding the and expanding the lumbar neural foramina and extending into the adjacent soft tissues. This, I don't think we have any pre or post, we don't have any post-contrast sequences, but in terms of shape and morphology, I think this is consistent with the plexiform neurofibroma.
Yeah, so plexiform neurofibromas are exam cases, and please remember that plexiform neurofibromas, 10 to 15% in literature, there is malignant transformation. So beware. And last time somebody got it actually with malignant transformation. And so in plexiform neurofibromas, as this film tells you, this is bunch of grape appearance, it's going anywhere. Please also remember that plexiform neurofibromas can also happen in subcutaneous nerves. So a plain film and, a chest x-ray where there will be multiple nodules projecting right and left, and that is a plexiform neurofibroma. In this case, you can see that it is going, it is, speaking itself. There is nothing else. Look here in the subcutaneous fat also, there is plexiform neurofibroma. I've got 2 cases to go, and is candidate 8 still with us? Candidate 8. No. Yes?
Yes, I am.
Okay, because I think I just gave you 1 or 2 cases. So candidate 9, candidate 9, thank you very much. I just want to give last 2 cases to candidate 8. She did not get enough today. So last 2 cases of the day. What is happening here?
So I've got sagittal T2s. There's widening of the cervical canal and dural ectasia.
Okay. And what is happening here?
On the coronal, there's kind of expansion with hyperintensity, which is suspicious for a plexiform neurofibroma.
Excellent. So now this is a unifying diagnosis where you pick this up, and you have got your diagnosis. Last case of the day. Yes, please.
Okay, so 50-year-old man, shortness of breath, frontal chest radiograph. There is a mediastinal mass projected over the left apical region. There is so it continues into the thoracic outlet, which intimates that this is a posterior mediastinal origin, and when comparing the 2 sides there is widening or splaying of the rib, so differentials would be a neural tumour that is causing
What will you do next?
In a 50-year-old, I could progress to a CT. If it was a younger patient, I would do an MR.
Okay, so
CT with arterial contrast.
You asked for a CT, I have given you a CT, and I got an
Thank you. Okay, so there is posterior vertebral scalloping, and it confirms that there is a posterior mediastinal mass that is emanating from the left intervertebral foramen, and there's a dumbbell configuration to the soft tissue mass that has kind of scalloped rather than destroyed the bone and the associated bone or the vertebra.
So do you think that there is a mass sitting inside this?
I think this is a neural tumour.
Neural tumour? So means a soft tissue mass? Can you do some technique on a CT scan to confirm that this is?
I could check the Hounsfield units and also contrast from a contrast. Oh, it's already contrast enhanced, isn't it? So it's not. So it could be a cystic, but sometimes you get cysts within.
Okay, so what will you like to do now?
An MRI.
MRI.
Yeah.
So intentionally, I have not given you post contrast or T1s, etc. But do you see that there is a tumor inside or there is no tumor inside?
No tumor inside there, like
Right. So conclusion.
So there's neuron enteric cysts that have caused widening of this.
No, it's the same thing. It's dural
It's still a
atresia.
neuron.
You see, the point is that this is what we call an unusual presentation of the same thing, and that is why I wanted to show you. This is the same thing as, dural ectasia, but this is huge, large.
Okay.
And dural ectasia is also known as pseudomeningocele. There are many teaching or learning points on this film, classical exam film. Now, when you get this kind of a mass, which is posterior mediastinal, now you picked up very well splaying of the ribs. Now, splaying, three things should be remembered. One is what we call ribbon-shaped ribs. Ribbon-shaped ribs are ribs which are dysplastic. So it's an inborn, the shape is not normal. Another concept is splaying. So if you see, splaying means the distance between this rib and this rib versus this rib and this rib, and there is splaying, means something is sitting in between the two. Third thing, pertinent negative or positive is there any scalloping? Superior rib scalloping and inferior rib scalloping is a differential diagnosis for your chest module. So it can cause this. If you see here, this case, this rib is slightly abnormal in shape. Of course, there is a bit of splaying also. When you compare this with this, the distance is increased. You pick up the mass. Let's go to the CT. Now on the CT, it tells you what can happen and how. Now there is posterior scalloping. All of this is scalloped. And you can see on this sagittal how the ribs or this sagittal, on this coronal or this sagittal, how the ribs are splayed, etc. On an MR, it then becomes clear that this is completely cystic and this is simple. We call it lateral meningoceles. This is simple dural ectasia. So the same thing, because it was so big, it was confusing us. And there is scoliosis also.